And good morning, good evening, good afternoon. Welcome to this week's Maternity Natural Health webinar hosted by INCO, the International Integrative Maternity Healthcare Organisation. And a big welcome along this week to Sylvia North. Sylvia, say hello.
Hello, Kathy. Hi, everyone.
It is wonderful to have you here. And we've got a really interesting topic today because it's just so incredibly topical and dominant and what's going on out there for the maternity journey experience. And what Sylvia's going to be talking with you today about is supporting that metabolic health of a mum and a baby through nutrition, particularly focusing on pregnancy and gestational diabetes. And gestational diabetes is a temporary form of diabetes that some pregnant women get, quite a lot, to be honest, and it's increasing. And around about 50% of women who get it have no risk factors for it. So it's often a real shock for the woman when they find out that they've got that. But just a little overview about Sylvia. Sylvia is an integrative dietitian nutritionist who's based in Auckland, New Zealand, who works with clients one-on-one to support women's health, fertility and pregnancy, their metabolic health, their digestive problems, etc. And Sylvia recently completed her PhD, so big congrats on that. That's no mean feat, which was exploring hyperinsulinemia, which is during pregnancy, basically, which is that high insulin, which is the side effect of having gestational diabetes. And nutrition, in her PhD was also talking about nutrition advice for women with gestational diabetes. Sylvia's interest in women's health started during her diabetes clinical training when she was working in the public diabetes service, working with women in gestational diabetes, with gestational diabetes, I should say. And Sylvia's mission is to help better inform and empower women and clinicians around how nutrition and lifestyle strategies can support women's metabolic health during pregnancy to prevent metabolic diseases from carrying on across the generations. Now, today's format will be that Sylvia's got a PowerPoint presentation that will take around about 40 minutes or so, but that's a bit flexible. And then there'll be time there afterwards for Q&A. And during that, she's going to be talking about hyperinsulinemia and insulin resistance during pregnancy, all those essential physiological processes and pathological consequences for women with metabolic dysfunction. And what to look for to identify women at risk of a metabolic dysfunction during pregnancy, and nutrition and lifestyle strategies to mitigate the risk of pregnancy complications, and low glycemic impact diet. Yay, what are the things that can be eaten? Healthy carbs and pregnancy superfoods, which will be so interesting. So welcome along, Sylvia.
Thanks, Kathy. Thank you. What a brilliant introduction. So shall I go ahead and share my screen?
Yeah, that'd just be wonderful. And for those of you who are live with us, if you've got any questions at all today, down the bottom of your screen will be the Q&A button, and you can just click on that and we'll absolutely make sure the questions are answered before we wind up in about 50 minutes from now. So I'm going to hand over to Sylvia, and yeah, it's great to have you here, and it's such an important topic. In fact, from a midwife perspective, the more that we can prevent women getting gestational diabetes, the better, because it's not just about the complications that occur for the pregnancy and the baby, but it's also the complications that really impact the birth, because so often those women end up getting induced, and that is just opens a whole other big, massive can of worms of consequences. So yeah, it's if we can keep women without gestational diabetes and without preeclamptic toxemia and without growth restricted babies, boy, you know, that makes such a difference to the birth and then the postpartum and everything else. So which I'm sure you're going to cover, but I will be quiet and hand over to you.
Absolutely, Kathy. That was really what that was the kicker, I guess you call it. You know, when I got into this topic, I was like, oh, you know, it's about, you know, we don't want to, people think it's about not having these large babies, but actually just the number of interventions that can occur if a woman's perceived at high risk in her pregnancy can have quite, you know, quite serious consequences just in terms of the management and, you know, just really taking a lot of that autonomy potentially away from women when you're considered, you know, a medical risk.
You're absolutely right. And, you know, because once somebody has been diagnosed with gestational diabetes and it's being managed, you know, in a reasonable level, then the ongoing consequences to the baby for a well-managed blood sugar level, you know, can become fairly insignificant. It's really when that gestational diabetes is not being managed that it will have the big consequences on the baby. You know, and most women are, you know, are pretty, as you know, we discussed in the green room before going live, most women are pretty obsessed with making sure that, you know, they're doing the right thing for their babies. But those interventions of the, you know, because women end up then getting induced into labor. And for those of you watching who don't realize why, the reason is because you're fully term, you know, from 37 to 42 weeks, and it's the normal time for a woman to spontaneously go into labor, somewhere around in that 5-week period between 37 and 42 weeks. But once a woman has gestational diabetes, you know, they once the baby gets over 37 weeks, the system is saying, okay, now it's time to get on and have with that baby. Why would we delay having that baby another 2 or 3 or 4 weeks, waiting for the woman to go into spontaneous labor with her diabetes getting more and more challenging to control? So the woman gets induced at, you know, typically around 38 weeks. And to put that into perspective, when I was a student midwife, in all of the years of being a student midwife, I never, ever saw a woman that was a first-time pregnant woman who was induced into labor. I never saw a labor end in a normal birth.
Exactly.
Horrific consequences of instrumental deliveries, forceps deliveries, Von-2s, C-sections, etc., because of the process of the induction. It is, you're so right, it is such a cascade of intervention.
Yeah, absolutely. I actually I looked at some of those guidelines for induction of labor while I was writing my PhD. And if you do have a woman with gestational diabetes that's uncomplicated, the guidelines don't say to induce. So
you're absolutely right, but boy, the system does.
So if you do have a woman who's kind of making the kind of having talk about that, but she's uncomplicated, then she can advocate for herself in that sense and talk to another obstetrician, because it would be also just a cultural practice thing. So that's a really tricky one.
It is. In fact, you know, when you've got women, I mean, obviously different countries have different abilities to exercise or women to voice, but it is very tricky because, you know, you can sit down with a obstetrician and there can be just little tiny words that they'll say that scare the pants off the woman, and she will give in to the idea of an induction, even though it's medically not strongly indicated for her. If her diabetes is well controlled, you know, I see it, and it'll be comments like, well, you know, your baby's quite a good size. Maybe we should be getting on with it. Some little comment like that. And the baby's not macrosomic, it's not large for dates, but they'll plant this little seed. And I know that certainly midwives, the independent self-employed midwives, when women are getting referred for a consultation on gestational diabetes, which is, you know, a typical part of the process, often there would be a situation of, oh, let's book her into the Tuesday clinic or the Thursday clinic or something, because we don't want her to see that doctor that does the Wednesday clinic, because we know he'll, you know, and it's almost like this protection of that intervention.
Oh, wow.
Yeah, because you don't get a choice, you know, in the public system. There's not always that choice. Now, in other countries, it can be different. But again, if you're paying, or your insurance company is paying for your obstetrician, well, that unfortunately is the one that you kind of have. Yeah. So they have if it's well controlled with diet alone, there's no reason to induce.
Yeah. And that's just it. It's what can we do early? And some women will still develop diabetes in their pregnancy, but what can we do to make that to help that woman be as healthy as she can throughout? And then we're going to be recommended fewer interventions. So yeah.
All right.
Shall I get into it? Yeah. Well, I just first had a little slide about me, but Kathy gave me a really good introduction, so thank you for that. So I got into this topic, and you know, so I'm based in Auckland. This is my darling puppy Tyson, who is a border collie golden retriever. Now, so we're going to spend a bit of time, first of all, talking about hyperinsulinemia and insulin resistance in pregnancy. So hyperinsulinemia is a great word for hangman, but it means having high insulin. And so the reason why I kind of really got into this is because it's the looking at the effects of this whole population metabolic health problem, and by that I mean the increasing rates of diabetes and obesity, and it means that actually there are more women who are now going into pregnancy with overweight, obesity, but also maybe metabolic dysfunction, and that risk of diabetes. So if you're at risk of diabetes later in life, then you're also at risk of having more metabolic complications during your pregnancy. So we're going to talk about just a little bit of the technical stuff, but then some more practical stuff for you about, okay, what do I look for? So who are the types of women that are more likely to be affected by complications, and what are the complications that we're talking about? And then some stuff around nutrition strategies to support a healthy pregnancy, including some, again, more practical stuff on a really good diet that can reduce some of these complications. So pregnancy, call it the essential metabolic storm of pregnancy. So I apologize in advance for the technicality of the slide, but I think it's really good to just contextualize what's going on. So pregnancy, there's a normal and essential process where you develop hyperinsulinemia, insulin resistance, and low-grade chronic inflammation. So from about the time when the placenta develops, around about 8 weeks, we start seeing increasing levels of these hormones that make the pancreas produce a lot more insulin and make the beta cells actually grow a bit bigger. And then so that's your prolactin and placental lactogen. They make increased levels of insulin. And then the placenta is producing growth hormone, progesterone, cortisol, and inflammatory cytokines that make the woman more insulin resistant. And the whole overall aim of these changes is to allow mum to develop fat stores to sequester nutrients that can then be transferred over to the fetus. So it's awesome physiology, awesome adaptative processes. But what's super interesting about this is all of these normal physiological changes are very similar to the dysfunctional processes that are seen when someone has metabolic syndrome, such as obesity or type 2 diabetes later in life.
Now, I took this little screen grab from just a paper from the Lancet, just showing some, again, for the biochem physiology nerds, so the metabolic changes that are really characteristic of metabolic syndrome. And a lot of these changes, like our inflammatory cytokines, the changes of insulin, changes in adiponectin signaling, these are all things that are also seen in pregnancy. So that's really interesting. What that actually means is if you've got a woman who already has some of these underlying processes, if she has excess inflammation, if she has already heightened insulin resistance or increased insulin levels, then the demands of pregnancy can push that over into what we kind of refer to as the pathological realm. So if you take a deep breath, I'll move on from the physiology, but I think that's really my technical brain finds that really, really interesting. But essentially, if you've got, if you have this metabolic dysfunction, then go into pregnancy, lots of things can go wrong during pregnancy if you're metabolically unhealthy. We talked a bit at the beginning about gestational diabetes, but there's a lot more. I first got into this topic thinking just really interested in gestational diabetes. I quickly learned about blood pressure abnormalities that can occur. So particularly insulin also raises blood pressure. That's why we see like hypertension with obesity and diabetes in the metabolic syndrome. Preeclampsia, blood pressure abnormality, but more so characteristic of changes in the placental architecture. Excess weight gain and weight retention, I mean, they're seen as maybe not significant risk factors, but really in the context of a lot of women who gain excess weight in their pregnancy might have difficulty with that for potentially the rest of their life, and impacts the medical management of her pregnancy, as we discussed. And really a lot of those delivery complications and trauma. So in my research, I did a case study of a woman who was young. She didn't have any, so to say, risk factors other than being overweight, but she gained excess weight in her pregnancy, and that led to recommendations for having an induction around 37 weeks. That also then led to a bunch of interventions through the delivery, including use of forceps and an episiotomy. And so we can just see that trickling effect of, because she was perceived as a high-risk pregnancy, and although the baby was perfectly healthy, perfectly normal size, they look at these, they look at these risk factors, and that can have quite significant effects on our woman's management and, the things that she's dealing with postpartum. When we think about the babies, we're thinking, oh, we don't want a baby that's large or small for gestational age. Yes, those are very common complications. But what I was quite surprised to learn about a lot of the congenital abnormalities that are much higher risk in women with obesity as well. So that's your cleft lip and palate and heart defects. But probably the deepest and the hardest complications to really wrap your head around are the lifelong risk of metabolic syndrome, increasing risk of childhood obesity and metabolic syndrome. So that's adolescents and young adults who can develop type 2 diabetes as a result of this transgenerational impact from the mother to the offspring. So that's our genetic programming as a result of the type of signaling that the baby is receiving throughout pregnancy. So a little bit about gestational diabetes. So gestational diabetes is technically defined as a carbohydrate intolerance resulting in hyperglycemia or any degree of glucose intolerance with onset or first recognition during pregnancy. So what that means is it's someone who has had their blood glucose measured during pregnancy and it comes up as high blood glucose. It rules out women who've had high blood glucose before pregnancy. So women who might have a slightly elevated HbA1c at the beginning of pregnancy, they're kind of referred to as more the pre-diabetic, or they were diabetic before pregnancy, managed slightly differently. So these are women who had perfectly healthy blood glucose levels, comes out around 24 weeks pregnancy.
The reason why that's around 24 weeks is that's when we're having the largest spike in insulin resistance. So the placenta is fully developed, fully active. We've got really high levels of all of these hormones making her insulin resistant and hyperinsulinemic, and that just pushes that over the threshold. In terms of prevalence, it affects anywhere between 6 and 25% of pregnancies. So super variable prevalence statistics. That 6% is recent from New Zealand, but the prevalence vary hugely dependent on the diagnostic criteria. Some places get everyone tested to screen for diabetes. Some places just screen the high-risk women. Some people use more strict criteria, others more lenient. So it's quite all over the show. And it's super recognized that the rates are increasing globally. That's because more women are entering pregnancy with our risk factors. So that's more women are overweight or obese in their pregnancy. More women have polycystic ovarian syndrome is another risk factor. And then we also must question this transgenerational effect. So if your mum had gestational diabetes, then you're more likely to have gestational diabetes in your pregnancy, and so on and so forth. In terms of the management, diet and lifestyle are the first line of care. So that's well accepted internationally, typically with the guidance of a specialist diabetes dietitian. And then they're offered oral hypoglycemics and or insulin as needed to reach the glucose goals. So that really puts a big emphasis on diet. A lot of the wording, like women write in forums like, I failed with diet, I've been recommended insulin or something. So there's a lot of emotion around having, trying to follow the right diet. But certainly, and this is some of the research that I did, where I interviewed a bunch of health professionals across New Zealand, dietitians and diabetes midwives who work in the area, and identified a lot of the challenges around gaps in care for personalisation of nutrition support. So it's a big systematic issue, and that's not unique to New Zealand. They've seen that in other places around the world. Really, to get a diet right for someone in such a dynamic time like pregnancy, you need several sessions. You need time to offer advice and then go away and modify it and make changes and adapt to things like constipation and pregnancy as well. So there's lots of room for improvement, I'll say. A little, just one more refresher in terms of the physiology. So just to recap, starting at the left-hand corner, we've got, if you have pre-existing hyperinsulinemia and insulin resistance before pregnancy, then there's the increased physiological demands for more hyperinsulinemia and more insulin resistance. And when these two combine, that's where we have metabolic dysfunction. So that can mean high blood sugar, so hyperglycemia. It can mean dyslipidemia, so having higher levels of certain cholesterol floating around the blood, and chronic low-grade inflammation. As that nutritional environment is floating around our fetus, our placenta and fetus, then there's increased nutrient transfer to the fetus, who then receives overnutrition. And as a result of having excess glucose, excess lipids, excess protein, the fetus responds by producing extra insulin. So that means fetal hyperinsulinemia. And a fetus that produces too much insulin may then grow quite large, but it could also mean affect a number of sort of developmental processes. That's where we see macrosomia or large birth weight. Not in every case, but really the concerning long-term effects is this in utero metabolic programming. So this developing infant is now receiving a lot of signaling where their bodies become thrifty for carrying extra weight in childhood and early adulthood that carries as a risk of obesity, type 2 diabetes, and metabolic syndrome, cardiovascular disease later in life. So why is metabolic dysfunction in pregnancy so relevant? I wanted to spend a bit of time just talking about those risk factors and how you might be able to identify someone who's at risk, because we're not just talking about the women who get high blood sugar. This is really important to recognize. It's you might get high blood sugar, but you also might get high blood pressure. So there's a bunch of complications, as I indicated previously. But if you look at the risk factors, well, literally everyone will have at least one of these driving forces that affects how your body responds to the demands of pregnancy. So if you have a family member who's had diabetes, if you're physically inactive, if you eat ultra processed food, if you have low vitamin D, so they're really common suboptimal environments, right? But some risk factors are stronger than others, and what we actually really need is to have some form of metabolic risk screening assessment, where if a woman meets several criteria, then they could be provided early nutrition advice. So this is something that I'm pushing for. I'm sure there's a lot of other people in the space who are really pushing for having a more robust screening system. But it means, like, if you've got a woman who's had hypertension, if she has high cholesterol, if her blood sugar is above, her HbA1c is above 38, or her liver enzymes are elevated. These are, so the biochemical markers are quite strong risk factors. And I really think we should have a doctor's assessment where you can actually just go, okay, you meet so many of these criteria, you're a 5 out of 10 or something like that. And that means that you qualify for additional support, or, you really need to focus on diet because your risk is such and such percent. Although we do have this, so there is obviously the screening there for gestational diabetes. If you do have high blood sugar, that does result in early screening or history of gestational diabetes. But we're not looking at that bigger picture, which is sort of looking at your risk of preeclampsia, for example, which is closely related to the metabolic issues similar to gestational diabetes. So I wanted to spend a bit of time on some of the nutritional strategies for pregnancy through this lens that recognizes that insulin resistance and hyperinsulinemia as the most significant nutritional challenges during pregnancy. So again, in my ideal world, where a woman who's maybe planning her pregnancy, or she's just found out, she has identified a number of risk factors that might mean that this is potentially something that she needs to be aware of, then she can come in with some nutrition support, or have some really specific things to focus on with her diet and lifestyle to hopefully mitigate the risks. So firstly, sort of just looking at nutrition strategies in pregnancy, we're balancing a lot of things. It's a real balancing act. First of all, we're balancing the effect, the overall nutritional requirements. So we're needing more overall energy, more protein, more fat, more water and salt, and micronutrients. So all of these needs go up, which means that we need to be eating well. And if you think about this, just even as a basic concept, obviously professionally, I give nutrition advice, and I meet a lot of people who aren't necessarily meeting their protein requirements on a daily basis. So to have then the extra demands of pregnancy, that alone is quite a challenge. Now, in addition to having all of these, excuse me, so alongside this, we're also seeing the increasing insulin resistance and hyperinsulinemia. So you're going to hear me, hopefully you've heard me say this phrase enough now by this time of the talk. But really that means that we want to be focusing on stabilizing blood sugar levels. But in that insulin resistance and hyperinsulinemia, again, if a woman has the pre-existing form and she's got more this pathological presentation, we're going to see an increased drive for weight gain in pregnancy, particularly in the first half, which can mean a greater risk of exceeding weight gain targets. So we're looking at meeting weight gain targets. I know I have to be quite tactful around, you have to be quite tactful around talking about weight gain in pregnancy, but It's also generally, if we get them on the right dietary strategies, that's something that will mitigate excess weight gain. And of course, we're also working around the food safety needs and changes in appetite, aversions, cravings, all of those very delightful things that can happen. So first of all, in trimester 1, there's actually no additional energy intake required in trimester 1. That's really important to know. It was obviously a cultural thing where people find out they're pregnant and they want to eat a lot more. And then we've got some quite significant appetite changes at this time. Eating enough can be a challenge for some people. It can go either way. Some people might find that some women might find that they are eating continuously to mitigate the sensation of nausea or discomfort in their stomach. And then because you're not feeling fantastic, there's a drive towards more calorie dense comfort foods. And if you're feeling quite rubbish and you haven't eaten much throughout the day, you might be leaning towards simple, easy foods that are often carby, fatty, and salty. We also might have a lot less movement and exercise because you're not feeling super flash. And this is where there's if you have excess weight gain in particular at this time in the first trimester carries a much higher risk of your gestational diabetes, but other complications. So this is, it's a shame because a lot of us might not necessarily have any contact with a woman in the first trimester because women are quite private at this time. You're not feeling flash, so you're just trying to survive through it. But it can be quite a challenge, when we're picking up women who've gained all their pregnancy weight from, and it's about 20 weeks in their pregnancy, because that can be quite a high risk. So if you do have a chance to have any kind of intervention, first of all, I just put weight gain targets from these are the Institute of Medicine weight gain targets. Now, generally in the first trimester, women aren't actually expected to gain a whole lot of weight in the first trimester unless you have an underweight BMI before pregnancy. So again, if we're seeing a woman with a high BMI who's gained 5 kilos or even 5 to 9 kilos in that first trimester, that can be quite a concern. So to mitigate that, what we're looking at is you want to be eating a low glycemic eating pattern, which we'll get into a little bit later. It's about having healthy choices where you can. And this is where the early pregnancy guidance really can go so far, or the preconception guidance can go so far, so you know what options are there. And it's not just the last minute, I'll grab some French fries from McDonald's on the way home type option. It's about eating little and often. So healthy choices little and often. Typically with appetite changes, we might be trying to have a larger meal earlier in the day, or having a really good dinner just at the time that you feel best, getting a really good healthy meal in. Again, we'll go into the specifics. And focusing on protein adequacy, because again, you're not feeling all that flash. We want carby, salty, fatty foods. And you might just under eating protein as a really typical issue at that time. And if you're not eating protein, then you're more likely to be craving carbs and sugar. Good time to talk about exercise, and good time to also look at vitamin D levels. Again, because we're going in for our first antenatal bloods, checking vitamin D, particularly in our women with overweight or obesity, because they're much higher risk of having low vitamin D. And we could go into a whole talk about vitamin D in pregnancy, because it's really important. In trimester 2 and 3, energy needs go up. So in the first half of pregnancy, it's called a more anabolic metabolism. So the body is building and storing. It's great. It's great. All these hormonal changes allow women's fat stores to expand. There's little changes in appetite centers that allow you to eat more without feeling full. Great. And then in that second or the later half of pregnancy, that's where metabolism becomes more catabolic. So energy needs are still much higher, but actually the metabolism is allowing a lot of your fat stores to now be broken down to transfer extra calories to the developing baby. We're a lot more insulin resistant. So this is where
there's a higher risk of problems to develop. This is why we typically have the oral glucose tolerance test around 23 weeks, where women, if you don't know what the oral glucose tolerance test is, it's around about anywhere between a 50 and a 75 gram glucose drink that may be taken non-fasted for the 50, fasted for the 75. And we're looking to see if she has a high glucose peak in response to drinking sugar. So the real goal is to stabilize blood sugar with nutrition. So we know that there's more insulin resistance, particularly these women at risk. Even if you're not diagnosed, we know that there's a greater risk of blood sugar instability. And women who might have risk factors, such as a previous gestational diabetes who doesn't get diagnosed in that 23-week test, she might be recommended another one a little bit later on. So it's still really relevant to be stabilizing blood sugar. In terms of diet, that means eating enough fat, enough protein, and enough fiber. Fat, protein, and fiber. I put some little images here of a delicious meatloaf. If you have heard of Lily Nichols, she has this awesome pregnancy superfood meatloaf recipe in her book, Real Food for Pregnancy, and it has liver mushed into it, and it looks kind of like that. So definitely recommend something like that in terms of a really nutrient dense, high protein food. Boiled eggs are great options as well. And we also want to be looking at hydration and salt intake. So traditional advice tells women to avoid salts if there's a high risk of blood pressure. I mean, at the end of the day, you actually need more salt during pregnancy and you need more water. So getting some salt in there is actually quite helpful. Mid to late pregnancy is also a good time to introduce magnesium supplementation if they haven't started already. A lot of these metabolic changes, just first of all, the increased nutrient demands of pregnancy, you're requiring more magnesium. But magnesium helps a lot with the body aches and sleep quality. So we're going to see a high risk of low magnesium levels, particularly maybe if the diet isn't having a lot of leafy greens. But most women are going to benefit from magnesium supplementation in late pregnancy because magnesium helps with insulin sensitivity and it also helps to lower blood pressure. We might also be including these conversations, a bit of chat around preparing for delivery. So it's more about, so in terms of postpartum meal prep, having healthy options around, and just looking to maintain healthy habits for those first six months of life, after introducing baby into the world. So, and those are really key, because again, a woman who's had gestational diabetes, around about a year after delivery, she's been asked to come back to screen for type 2 diabetes. So eating healthy throughout that period is also really key to then reduce the risk of postpartum weight gain or weight gain after in that first year of life again, and maintaining metabolic health. I'll spend a little bit of time on plasma glucose targets in pregnancy. I just have a couple of slides on this because, again, my technical brain finds it really interesting. You might be surprised to know that blood sugar levels actually go down when you're pregnant. You actually should have a lower fasting blood glucose level than when you're pregnant than when you're not pregnant. And why that's relevant is a woman with diabetes in their pregnancy, generally around the world, all different, most services recommend testing about 4 times a day using a little finger prick tester like this one. But the glucose targets can vary internationally. There, again, more inconsistencies in terms of management of things. But we know that from a really landmark study that was published in 2008, there is a linear and continuous relationship between glucose levels that are outside of the diabetic, in the diabetic range, so outside of normal, and your risk for complications such as fetal hyperinsulinemia and fetal overgrowth. So what that means is if you have blood sugar levels that are high, as indicated in diabetes and pregnancy, the worse they are, the worse outcomes there are. Which also goes into our conversation about, more interventions and all of that sort of thing.
something even more interesting in my little journey, just investigating these glucose levels, is there was a study done by Terry Hernandez et al. In 2011, where they did a systematic review where they looked at what is a normal glucose level in pregnancy. So these are all collated studies of like women on a hospital ward where they measured their blood glucose level several times across the day. And they came up with these weighted averages and recommendations for actually what it should be. So, they found that blood glucose levels are lower than a normal healthy person during pregnancy. And if we use that as the standard, then our glucose targets actually should be quite a bit lower than what we use in clinical practice. So what that means is if you have a woman, or if a woman with diabetes in her pregnancy, she has a few numbers that are just outside of range, that's actually quite far out of range for what a healthy level should be. So we're not being mean when we say there are these criteria if you're just off by just a point, because particularly if we adopted these more strict criteria, a lot more women would be out of range. The reason why this is relevant is because it means that there are actually a lot more women who are carrying on through their pregnancy with these borderline high glucose levels that aren't necessarily identified as hyperglycemia, but that's where we might be seeing the excess weight gain, still large for gestational age infants, or difficulties in delivery and labor, or blood pressure complications, but also just sort of looking at those transgenerational metabolic complications. Like if you just had that borderline blood sugar and a high background insulin that's not measured at all, those are the infants that might be developing childhood obesity or developing type 2 diabetes in their young adult life. So something to ponder. And again, it goes back to, systematic challenges when we look at guidelines. It's also all about cost, because it's particularly diagnostic criteria are looking at if we diagnose this many people, then our service has to service this many people. And if we open it, then we don't have the capacity to cope. In terms of diagnostic criteria, if you open up the criteria, then there's also that risk of over-medicalizing women who might be totally fine. So there's a lot of controversy around when we work out criteria like these. That's something to ponder on a clinical practice level anyway. So why don't we spend a little bit of time talking about eating for blood sugar stability? So if we're measuring blood sugar, or if we're concerned about our risk, actually, if I just go on to the next slide, this is what I mean by blood sugar instability. Okay, so our red line is our blood sugar level, and the green gap is maybe where it should be. And this is a modern metabolic problem, probably the most common nutritional issue that just people experience on a day-to-day level. We're busy and we want quick food. Traditional breakfast of toast or cereal is going to give you a spike in blood sugar, which then quickly drops down a few hours later. So I'm sure just about everyone has experienced the sensation of, maybe if you're a clinician, you've been in clinic for the last 4 hours, had lunch at 12, just trying to get your paperwork done to get home. You're in the car texting your husband, what's for dinner or what should I grab? And you're pretty impatient by the traffic. You've got a pretty short tether. You're feeling quite wiped out from the day. And I'll tell you that that's a low blood sugar sensation. So women in pregnancy typically don't get as many blood sugar crashes. Thankfully, a lot of the hormones allow you to kind of mitigate that quite quickly. So obviously, because if the blood sugar levels go low, that's that's quite dangerous for the fetus. But we still see it's those spikes. And if a woman is taking insulin, then she's at more risk of the blood sugar crashes. I think it's still relative, like certainly in pregnancy, women will get very intense sensations of hunger very quickly. So I think there's just a lot more like drivers in place so that you can, in terms of like hunger and helping to mitigate those crashes. But so we want to be sitting in the green zone, right? So Eating for blood sugar stability, it's about eating protein and fat in every meal, first of all. Protein and fat keep you feeling full. They stabilize your blood sugar. Protein and fat stimulate a bunch of hormones in the stomach, including such as cholecystokinin, that make you feel satisfied. And they slow the emptying of the stomach. Eating protein early in the day is particularly important. So especially in pregnancy, since since we have higher protein requirements, actually you really want to be focusing on eating protein in every meal, and particularly in that first meal of the day. You want to be limiting a lot of those refined carbohydrate foods and sugar containing foods. And those are the types of foods that are going to send the blood sugar levels up quite quickly. So those are breads, pastas, like noodles, convenience foods, chips. They're going to send the blood sugar levels up a lot more quicker. So doesn't mean to avoid them, but it means to limit the quantities of them. You want to eat regularly, or as often as possible, or as often as needed to, not as often as possible, as often as needed to avoid that low blood sugar response. So you want to have food available. If you're expecting yourself to go 4 hours between meals, breakfast, lunch, and dinner like you used to do before pregnancy, is only going to set you up for a lot of hunger. So we want to have options in terms of snacks and kind of knowing what's available. Avoid eating naked carbs. Now you get my hilarious joke with the gingerbread man. And that means, just try and encourage women to, if you're going to have a snack, don't just have fruit by itself. Don't just have a handful of crackers or juice, but combine them with some fat and protein. Like if you're going to have some fruit, have it with some yogurt or cheese and crackers, fruit and nuts. And what that means is that the protein and fat in those foods will actually fill you up a bit more and mean that snack then carries you a lot longer. Avoid missing meals, days of trying to grind through a morning and not really packing a lunch with you. Don't do that. And avoid caffeine on an empty stomach, although that's typically not such an issue in pregnancy because we're usually not having very, very much caffeine, if any at all. When we look at carbs a bit more specifically, because I did say limiting the amounts of refined carbs, that's because carbohydrates are the only foods that significantly increase your blood sugar levels. So foods that contain carbohydrates are broken down into sugars that are released in the blood. If a woman has glucose intolerance in pregnancy, she must monitor the amount of carbs in her meals to achieve glycemic control. And that means having awareness of what foods contain carbs and having awareness of what contains protein and fat so that you can combine them and be quite conscious of the portion sizes of carbohydrates. The guidelines are knowingly very controversial and outdated. When I was doing my dietetic training, everyone was given 175 grams per day minimum, but that is kind of, it's moving out. The problem is this 175 gram per day minimum appeared on a USDA Institute of Medicine document many years ago. Can't remember when it was dated for, based off questionable evidence. It's a calculation based off the estimated requirement for adults, and again, totally all calculation based. But in practice, so that it's on its way out, that's for sure. But again, guidelines are tricky. But in practice, a woman actually may have anywhere really between 80 and 125 grams per day. 80 being the lower end, obviously. So totally varies. And that's really about looking at that woman's insulin sensitivity, their pre-existing diet, and if they're measuring their blood sugar levels, we're looking at their blood sugar response to their diet. When we're recommending, we're looking more at carbohydrate control across the diet, it's always personalized. Generally, you spread it across the day. There might be less carbs in the morning because that's when a woman is more insulin resistant. So this again is a lot more specific for when you're measuring blood sugar levels, because that's when you're more likely to see those post-meal spikes. And having larger portions around her most active time. So again, if you're like busy at work, it's not a good idea to have a tuna salad and an apple. If you're, quite active and then wanting to go do some exercise after. So being quite smart around actually having enough is also really key. This is the fun slide. This is the fun slide. So a low glycemic eating pattern, here's my example of what a low glycemic eating pattern might look like. So these lovely colorful pictures. So first of all, for breakfast, it could look like having some eggs where you cook it in some butter, serve them with some avocado, salt, and a couple of slices of toast. I would typically actually get a woman to have at least 3 eggs in the morning for breakfast, even though that image suggests it's just 2. Then a couple of hours, have a mid-morning snack. That could be some fruit with nut butter, where that's about 10 to 20 grams of carbs. Lunch, a roast vegetable salad. If we have some sweet potato or pumpkin and a good amount of chicken, olive oil, greens, that could be 20 to 30 grams of carbs from the starchy veg. Mid-afternoon snack, you might have a protein smoothie with frozen mango, greens, coconut milk, and protein powder for another 15 to 20 grams of carbs. And then dinner, if it's just a standard meat and 3 veg type meal with a handful of starchy veggies, potato, and then half a plate of non-starchy vegetables cooked in olive oil with salt, that could be another 20 to 30 grams of carbs. Then supper might look like having warmed berries with Greek yogurt, another 10 to 15 grams of carbs. So I was being quite broad in terms of the amounts there, but it might equate to anywhere between 90 to 145. And that would be, grams of carbs. In terms of pregnancy superfoods, love that term. Maybe not. It's got a bit of, got a bit of charge behind saying superfoods these days. But just a lot of foods that we try to encourage in a healthy diet of pregnancy. You want to eat all the non-starchy vegetables, lots of non-starchy vegetables, so they provide a lot of micronutrients and fiber. It's great to encourage lots of soluble fiber foods. So if we don't have an issue with blood sugar, kiwi, prunes, prune juice, or oats, but in terms of low carb options, you can do chia seed and psyllium husk. Eggs are a really great meal to include, so that's why that was in our breakfast option. Try to encourage women to eat eggs every day if you can, so because they provide a brilliant source of choline, which is really key for fetal brain development, protein, obviously, and a lot of vitamins. Organic liver, again, another source of controversy. A lot of guidelines tell women to just avoid all liver products in pregnancy due to concerns about the teratogenic effect of vitamin A. In terms of the amounts, if you limited liver intake to 30 to 60 grams a day, so that's a small amount, maybe mixed in some mincemeat a couple of times a week, then that's going to provide you a really good amount, a healthy but not excessive amount of vitamin A, your iron, and your B12, as well as a bunch of other minerals and B vitamins. So it's incredibly nutrient dense. Full fat dairy products are also really great to include, so particularly our Greek style yogurt. That's because they have a lot of our fat soluble vitamins, minerals such as calcium and magnesium, and obviously act as a source of protein. And particularly late pregnancy, sort of a lot of like Eastern practices encourage slow cooked meats and broths, and that's because broth contains collagen and glycine, which glycine is essential during pregnancy. It's actually an essential nutrient during pregnancy that you don't get in your diet from any other types of foods other than the collagen in animal products. And then, obviously as a source of protein, but collagen, obviously when you're getting all this growth and changes in your body, all of that extra skin, extra changes in your connective tissue requires collagen as well. And having warming food, again, for Eastern philosophies. Those were, that's what brings me to the end of my slides. So thank you, Kathy.
Oh, that is awesome. Thank you. Do you want to unshare? There we go. Perfect. So interesting, so interesting. And even the idea of the 3 eggs for breakfast every morning instead of 2, you know, because it's all about that protein, and the protein with the fat. It's just you kind of can't go wrong with having that as that priority. I one of just some sort of questions that we'll throw in there as well. I know that with myself, with clients, I will often suggest a sweetener called stevia, which is a natural sweetener, which is, to my understanding, is a 0 glycemic index. So it's great for those people who, you know, really like to have a teaspoon of sugar in their cup of tea or something. You know, it's the way that they can have that sweet taste. But what about artificial sweeteners that are out there, those sort of synthetic ones? What's your thoughts on sweet sugar substitutes?
Yeah, yeah, I totally agree. You need to give women options, that's for sure. When you go from a certain way of eating to then recommending no sugar, you need options. Personally, I'm not comfortable recommending artificial sweeteners. There's a certain number, a couple are actually recommended to avoid. So cyclamate, which is actually, as far as my knowledge, is banned in the UK, but we have it here in some foods in New Zealand. So cyclamate is absolutely avoid. But yeah, I'm personally not comfortable recommending artificial sweeteners because it's all an unknown, you know, and when you take some kind of artificial chemical,
1000% agree with you. You know, we don't have you know, big long retrospective studies of, you know, when somebody's been exposed to those artificial sweeteners for, you know, 50 years of their life, what's the you know, we don't know that stuff, and they are you know, touted as safe, but we can't really say that. But you're happy with stevia?
Yeah, I'm comfortable with stevia, but I think you know, well, there's a lot of more just awareness about how, like, the fetus actually will taste the food that woman is eating. So if you're eating a lot of really ultra sweet products, then how is that, you know, I might hypothesize, how is that going to affect the taste perception and the expectations of baby as they're starting to engage in real work and food in the real world as well?
Yeah, you're giving birth to a baby with a sweet tooth right from the get-go.
Yeah, imagine that. Yeah.
That's and I loved all your medical explanations and sort of, you know, understanding the physiology of what's going on. I think that women, when they you know, when they get given that knowledge of what's physically happening inside their body, and you know, how it can negatively and positively affect things when they are, you know, change lifestyle. You know, women get empowered by that. And it does frustrate the heck out of me when I see stuff really dumbed down to an oversimplistic form of explanation. You know, one of the things, so we know that with women who have got out of control diabetes, that, you know, we see these large babies, and it's, as you explained, that because the baby has to produce more insulin to cope with that maternal highly sugary blood, the side effect of all that insulin that the baby's pancreas is producing for themselves is that it acts as a growth promoter. So we get these really I call them cherub looking babies. They just got these kind of no neck little, they're just Buddhas. They look like little Buddhas. And it's not normal. But the other thing that is quite scary is the other sort of one of the more common aspects of those consequences is that these babies' lungs don't mature in the same way. So it affects their, which I know that you know about, but just explain a little bit more here, which it affects the surfactant within the lungs. So now what happens is that these babies are born not just with these huge Buddha cherub looking things, but also they can fairly quickly get into respiratory distress because of the fact that their lung surfactant isn't as mature as it should be, ready for being born. So that adds to it. And then of course, because they've suddenly lost at birth, they've suddenly lost access to that sweet maternal blood sugar, high blood sugar levels that's circling through the mother system and then through their system, then they will plummet in their own blood sugar levels. So so all this extra monitoring is done, and that, you know, until that baby has managed to maintain normal blood sugar levels for itself for about sort of the first 12 hours, and then they kind of come out of that danger zone. So there's so many things that impact. Another product that I've often recommended to women, which I guess you'd know all about, is shirataki noodles, which
okay.
Because it makes you feel like you're eating a carb because they're noodles, but they're 0 on the glycemic index. So again, it's one of those ways that you could sort of cheat a little bit, what sort of feel like you've carved yourself out on a lovely noodle meal. And I also think that little comment that you made about avoiding the naked carbs, like you know, fruit juice and crackers on their own. What is, you know, that's such a simple thing to explain. You know, just add that little bit of fat or protein to them to make such a big difference. I guess the only other things I was sort of wondering about is, I know the answer, but it'll be interesting to get your take on this. You know, when a woman has had gestational diabetes, you know, is she going to get type 2 diabetes later on in life?
That's what everyone, well, that's what the big fear is, you know, you're going through this traumatic experience. So there'll be screening immediately after to check if she's to check that metabolism has gone back to normal, and it's more likely those women who had like quite borderline, maybe pre-diabetes, that could flick into type 2 from the pregnancy. So that's that initial. Now,
and I might just add into that it is relatively rare. So most women, you know, a little while later after having their baby, they'll go and have another blood test, and usually women have returned to normal. But it certainly does add to a bit of a red flag that later in life they are a bit more prone to going into, and really those women who after the pregnancy don't recover to normal and are still showing diabetes, chances are they had diabetes before they were
exactly. No, exactly. So it's said that about half of women who've had gestational diabetes will develop type 2 diabetes within 10 years.
Within 10
so
years.
that's you know, you can, and
within 10 years.
Gosh.
Because I mean, you know, most of our women are, you know, in their late 20s and 30s having babies these days. So that means before they're even 50.
Yes. So, and that can be, you know, you can also just look at that lifestyle of where things could go. Maybe there's a second baby, there's increased, you know, more weight gain between pregnancies. Also, you've got a child, and you know, it can just be quite a busy time in life where if you don't recognize actually this could go in this direction, then it can be quite devastating. But that means that you've got you could have a 10-year-old and have type 2 diabetes.
Wow.
Yeah.
That's pretty scary. I mean, I knew about it being 50% chance of developing type 2, but I hadn't heard about that statistic about it in the first 10 years. That's pretty high. Very high. It's pretty young, you know.
It's young.
And so what are the best tests to do what do you think are the best tests to do before pregnancy or in that first trimester, you know, to review a woman's metabolic risk? Now, obviously there's the HbA1c, which is a particular test that looks really over the previous 3 months, and
Mm.
that woman's body been in a metabolic state. But any other commentary on tests?
Yeah, so in an ideal world, we're getting everything tested before pregnancy, and because some bloods might not tell us as much in those first few weeks, but either way, HbA1c, that needs to be, ideally under 38, so really within the healthy range. If it's just edging on 39, 40, that's a risk factor. So all the biochem, you can look at your liver enzymes, you can look at your lipids. So if your cholesterol levels are out of range, particularly triglycerides and HDL cholesterol, so those are really significant metabolic risk factors. Triglycerides go high when you're eating more carbohydrate and sugar and are insulin resistant. So triglycerides are what you want to look for on your cholesterol panel. And so and blood pressure is another risk factor, but then also looking at your family history, waist circumference, or one researcher used neck circumference. In pregnancy, again, your waistline might not be the best indicator, but neck circumference, there's some reference ranges there, but that needs to sort of be developed. So healthy weight, eating a healthy diet is really key. So it's really looking at, if you do have some of these risk factors, this is the time to go see a dietitian, nutritionist, go see someone, get some really good solid guidance on how do I eat healthy to reduce the risk of anything going on and get really on track. Then
Yeah, and of course, all of that preconception healthcare, ideally, 3 to 6 months for the male partner and 6 to 12 months for the woman, before you're planning to have a baby. And it's also not just setting you up for lower chances of obstetric complications in the pregnancy, which could lead to obstetric complications. But of course, it also is going to make the healthiest sperm and the healthiest eggs, healthiest womb lining. So it's it's a better chance of that pregnancy even successfully establishing. Hey, just the last comment. What are your thoughts with regards to the best way to monitor a woman her blood glucose level without or before they are going to have their glucose oral tolerance tests, in pregnancy?
Yeah, so because the glucose tolerance test is obviously, it's done like late gestation, around about 25 weeks, and it's also a very artificial situation. Like, you're never going to have 75 grams of sugar for breakfast. So it's a very artificial situation, but there is potential that, like, particularly your midwife could suggest someone who's at risk to do a few finger prick glucose tests to detect it early on, and just giving her a little monitor to take it away and do a few fasting measures. Some women can find that quite invasive, or just a lot to take on, because you don't want to act like you have diabetes if you don't have diabetes, but just have a bit of knowledge around it. What's really cool these days is you can buy the Libre Freestyle sensors, which are these two-week little sensors that go in the arm, and they measure your glucose levels across the day. So that can give you some really good feedback of what you're experiencing, and give you some good feedback about your food choices and things like that. So, and then also monitoring weight gain as well. Like I said in one of my slides, if you gain more than 2 kilos, if you gain 5 kilos in your pregnancy in the first trimester, then that's a high risk, and maybe we really need to be looking at diet early on there if that weight gain is happening.
Yeah, that's an interesting comment that that you're making, that's quite a red flag to see a more than 2 kilos go on in that first trimester. Bearing in mind that your baby weighs nothing like that at that time. So but it's just been so fascinating having you here, Sylvia, and you've got some really wonderful overviews there that we've gone through. Before we wind up today, is there anything else that you would like to just add in as a conclusion that maybe we haven't covered? And also, can you just go over your contact details as well?
Oh yeah, absolutely.
For people who might be watching this webinar, you know, much later down the track.
Yeah, absolutely. Yeah, so my my business is Fearless Nutrition. So my contact, my email is on that website. If you do have a look at fearlessnutrition.co.nz. Yeah, final comments. God, I just wish a lot more women would know about the risk factors, because I think we everyone just goes into pregnancy hoping, just hoping for the best, and it's this like magical, it's perceived as this magical experience of the body, and I hope my body works right, but actually there's so much in your power for how healthy your body can be in pregnancy. And I think that empowerment is something that, as health professionals, we really want to, we're big advocates of, and just the dumbing down of medical information. So often, I was going to say that in Facebook forums, I see women say, it's the placenta that's making the blood sugar levels go high. It's the placenta, it's nothing to do with you. But actually, you are the placenta. So, your choices do impact the placenta. And just if women had a really good lists of these are all the things that you can focus on, there's just so much we can do there. So yeah, if you wanted any of the references, please get in touch with me and I can send those through to you. And I think Kathy is going to send through an email with the contact details. But
so those people who have registered for this webinar will receive contact details tomorrow for all about how to get in contact with Sylvia. And again, so those of you who may be watching this later down the track, her website is Fearless Nutrition. So that's just all one word, Fearless, FEARLESS nutrition.co.nz. And then her email is Sylvia, so SYLVIA, at fearlessnutrition.co.nz. So we've gone over time here today, but it's just such a common complication of pregnancy these days. It was worth us, deep diving a little bit longer in on this topic, because it's relevant to so many women and clinicians who are dealing with women who have gestational diabetes. So thank you so much, Sylvia, for your time, and thank you, for focusing your PhD on this topic. The more that we know, the more empowered women can become. And so thank you, and thank you to those who are here live today. We always appreciate your presence, and we here at IMCO, we just want to wish everybody a wonderful rest of their week. So thank you so much. Bye everybody, and bye Sylvia. Thank you.
Bye.